Hey again, this is Chris Camellia with another installment of This Week in PT School I Learned. It's been a little bit. I had an exam and a practical. My first ones did pretty well. And so what happened was wasn't able to update the videos like I had planned. So going to try and summarize week 3 and 4 of physical therapy school. And there's a lot of information here. So it's going to be inherently an incomplete endeavor. First off, learned about the intrinsic hand muscles, particularly the palmar interossei, as well as the dorsal interossei and the lumbrical muscles. I've taken the liberty of drawing the hand muscles on myself, so hopefully this can be a solid learning experience for you. What we have here are the 3 palmar interossei. They attach to the proximal phalanx, the base of the proximal phalanx of digit 2, digit 3, and digit 4. The palmar interossei muscles adduct the fingers, but really just fingers 2, and finger 4, and finger 5. Alright. Finger 3, the middle finger, doesn't have a palmar interosseous muscle. It's the midline. It is adduction. It is adduction. It is already adducted. So the middle finger, for it to move in the frontal plane, it would have to abduct, abduct either direction, which is why the middle finger has 2 dorsal interosseous muscles. So there's an interosseous muscle here, an interosseous muscle here. They both serve to, forgive me, abduct finger 3. Finger 3 only abducts. Hopefully you appreciate this. So our dorsal interosseous muscles, they abduct finger 2. 2 of them abduct finger 3. 1 of them abducts finger 4. Alright. What's abducting finger 5, you ask? Well, that's certainly the abductor digiti minimi. And that actually attaches at the base of the pisiform muscle, pisiform bone. And that is responsible for abducting the pinky finger. So usually what happens is these three fingers, they're kind of in cahoots, and then pinky finger and the thumb, sometimes they kind of do their own thing. Next we have our poorly drawn lumbrical muscles. Those attach to the metacarpals of the same fingers that they attach to distally. So it's on the metacarpal on the palmar side, and then it's on the radial side of the proximal phalanx for fingers 2, 3, 4, and 5. These 4 fingers. What do they do? These muscles attach on this side, and they serve to kind of bring the hand together, kind of like that. So if it's on the palmar side, it's going to be an adductor, adductor. If it's on the dorsal side, it's going to be an abductor, abductor. What's interesting to note about these is the lumbricals to fingers 2 and 3. Those are innervated by the median nerve, and then the lumbricals to fingers 4 and 5 are innervated by the ulnar nerve. You can remember that because the lumbricals to fingers 4 and 5 are also bipinnate, meaning they have 2 muscle bellies. So that's just a neat little fact for you. All of the interossei muscles, the dorsal interossei, the palmar interossei, as well as the lumbrical muscles, they attach to the extensor mechanism, and they cross the MCP joint, so the metacarpo-phalangeal joint. They cross here on the palmar side, so they serve to flex the MCP joint, whereas they cross behind on that first phalanx, and then they insert on the dorsal side of the rest of the finger. So what they do is, when they contract, they also do that. So all of them attach to the extensor mechanism, and they do that. I've drawn the extensor mechanism on the back side of my index finger, finger 2. The thumb is a finger. And I've drawn the extensor hood, which wraps around the metacarpo-phalangeal joint, the joint between the metacarpal bone and the proximal phalanx, and they attach to the volar plate, which is essentially a ligament right along the palmar side of the joints on your finger. So your distal interphalangeal joint, your proximal interphalangeal joint, as well as your metacarpo-phalangeal joint. The rest of the extensor mechanism, we have our central slit, which will extend the proximal interphalangeal joint. We have our lateral bands, which run alongside and cross on the sides of the proximal interphalangeal joint. And then on the middle phalanx, they run and connect to each other. And then they cross and attach and insert all the way at the base of the distal interphalangeal joint. Sorry, the base of the distal phalanx. So, whenever we extend our fingers, the rest of this will kind of follow suit. Now, might not make a whole lot of sense. It didn't to me at first. What I had to realize was that if we're pointing, these lumbrical muscles are working to flex our metacarpo-phalangeal joint to neutral. So if we are extending via our extensor digitorum muscles, or as well our extensor indicis and our extensor digiti minimi, as well as, we'll count the extensor pollicis, longus, and brevis here. So we're extending with these muscles. If we didn't have lumbrical muscles or our flexor digitorum muscles working, we would hyperextend this metacarpo-phalangeal joint, which we wouldn't want to do. So our hand intrinsic muscles are actually working to keep us pointing straight and not hyperextending. I can't really do it that well, which is a good thing. Not hyperextending that metacarpo-phalangeal joint. There's a really cool video that I will post that illustrates very well. Spoiler alert, it's a little graphic. It's with a cadaver. It's a little bit old school, but it demonstrates really well how these muscles work together to perform actions like a finger sweep, and kind of coordinating that. And so they have these kind of pulley systems. You can see that when some muscles aren't working, it doesn't work out quite as well. But it's a really good video. Again, I'll post it below. I had to watch this one a good 5 or 6 times in order to really understand, like, that's how that works. So basically we have these ligaments that kind of hold down the flexor digitorum profundus tendon, which really goes all the way along here, but I've just kind of, for illustrative purposes, I've just kind of done it up here. We have these annular and cruciate ligaments. Cruciate ligaments cross each other. The annular ligaments are just kind of one directional. We have these annular and cruciate ligaments that hold down the flexor digitorum profundus tendon to the finger so that bowstring doesn't happen. So if these ligaments were injured, the flexor digitorum profundus tendon would really pull down and out, and it would kind of look like a bowstring. Hopefully you would have skin there, and it would kind of look like you kind of pull it back and fire an arrow that way off of it. So really fortunate that we have these so that the flexor digitorum profundus tendons stay on our finger and move it the way we want to. And the flexor digitorum profundus can curl all the way around here and flex our distal interphalangeal joint, whereas the flexor digitorum superficialis kind of splits. And it's a little messy, but I've kind of marked it right here. Flexor digitorum profundus superficialis, splits. And if you're only contracting your flexor digitorum superficialis, it'd kind of look like that. Whereas if you had your flexor digitorum profundus as well, you can do that. So the deeper muscles can do a little bit more precise things. Also, in your hand, there are these tiny little arteries that provide blood supply to the flexor digitorum profundus and superficialis tendons. And they provide very minimal blood supply, but they do what they can to the, again, those tendons coming from the bone of your finger. And these little arteries have these connective tissue sheaths, and together they make up what are called vincula. Vincula. Singular is a vinculum. They're these tiny little arteries in your hand that help keep your tendons nourished. Moving on to week 4 in PT school, I learned that the omohyoid, one of your infrahyoid muscles, attaches at your scapula, and it attaches at the hyoid bone. So it depresses the hyoid, can also elevate your scapula. If your scapulae are too far depressed, that could affect how your jaw works, how your swallowing is, a number of different things. So don't count out the omohyoid just yet. Speaking of small little muscles that some people forgot about, our psoas minor attaches at T12 vertebrae on the anterior side, as well as the L1 vertebrae on the anterior side and kind of on the sides as well. The psoas minor then attaches to the pectineal line of the pubis bone, basically the front of your pelvis, and the psoas minor will posteriorly tilt the pelvis. Psoas minor will posteriorly tilt the pelvis. The psoas minor will posteriorly tilt the pelvis. I also learned that the two muscles that attach to the iliotibial band are your gluteus maximus on the posterior side, originates at your posterior sacrum, and then it attaches not only to your gluteal line, basically the posterior and superficial portion of your femur, but also that gluteus maximus, that hip extensor and external rotator primarily, might do a little bit of adduction. Your gluteus maximus also attaches to the iliotibial band, which runs along here, starts at the lower part of your knee. Whereas the tensor fasciae lata originates at the anterior superior iliac spine, also attaches to your iliotibial band, and it is a hip flexor and a hip abductor, but it's also a hip internal rotator. Alright, so these muscles are majorly opposing each other, right? One's a flexor, one's an extender, one's an external rotator, gluteus maximus, one's an internal rotator, tensor fasciae lata. However, neither of them really adduct. Alright, definitely not the tensor fasciae lata, and probably not the gluteus maximus a whole lot. Therefore, sometimes what might be causing our iliotibial band issues is we are either lacking adduction, or we're already so far adducted, basically we're not moving in the frontal plane. That's what I'm trying to get at. So if our tensor fasciae lata and our gluteus maximus, another reason is those are both superficial muscles, and so those big movers could be kind of causing a lot of tension on there, where we might not have as many stabilizers helping out, and so when those movers have to stabilize, you're going to have a bad time. Therefore, maybe, just maybe, we're having excessive iliotibial band syndrome because we're not moving at all in the frontal plane. So we could either be too far adducted, right, if our iliotibial band is taut, right, or a whole lot of time in an abducted position might shorten it, right, and make it more short, sort of short and stiff. Either way, again, it comes down to a lack of frontal plane movement. So move more in the frontal plane, and just maybe some of that iliotibial band syndrome starts to take care of itself. One more thing worthy of mention is that your piriformis muscle is a hip extensor, a hip abductor, abductor, and a hip external rotator. So the piriformis muscle, therefore, if you're trying to stretch it, if it needs to be stretched, it's a whole other conversation we could have, but the piriformis muscle, that will be most elongated if we are flexed and adducted and internally rotated. So a lot of times I've heard this called a piriformis stretch when we're either in a what do you call this? The pigeon, or like a figure four stretch. And so if we are externally rotated, and abducted, are we really hitting our piriformis with that one? So that's just some wisdom from a ya boy.